Hello, everyone, and welcome to today's live broadcast, Biosafety Risk Assessment Fundamentals for Clinical Laboratories, presented by Mike Pentella, PhD, Clinical Professor at the University of Iowa College of Public Health. I am Christina Mahalik of LabRoots, and I'll be your moderator for today's event. We are delighted to bring you this educational web seminar presented by LabRoots. LabRoots is the leading scientific social networking website and producer of educational virtual events and webinars. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. Just click on the green Q&A button located in the lower left of the presentation window and type your questions into the box that appears on your screen. We'll answer as many questions as we have time for at the end of the presentation. Also, please notice that you will be viewing the presentation in the slide window. To enlarge the window, just click on the screen icon located on the lower right. If you have trouble seeing or hearing the presentation, please click on the support button at the top right of the presentation window, or use the Q&A button to let us know that you're having a problem. This presentation is educational and thus offers continuing education credits. Please click on the button in the bottom left corner and follow the process to obtain your credits. Now, please join me in welcoming Dr. Pentella. I will now turn the presentation over to him. Dr. Pentella?
Welcome everyone to our session. On risk assessments. I have nothing to disclose on this first slide. Moving to the second slide, today's title is Biosafety in Risk Assessment. Many of you are learning how to perform risk assessments in your laboratories, and I hope that this will give you some further information. My first question for you is, are you a risk taker? What is the riskiest activity you have ever engaged in? As you can see from the photos, in our leisure time, there are a lot of risky activities that we do. One of the things we don't want to do is engage in risky activity in our workplace. We want our work environment to be as safe as possible to protect ourselves and our colleagues from acquiring a lab-acquired infection. Going on to the second slide, look at the changes in laboratory safety during the last 50 to 60 years. The picture on the right is from the archives of the State Hygienic Laboratory here in Coralville, Iowa, around 1950. And as you can see, they're working in the laboratory without any sleeve protection. It was very common at that time to eat and drink in the laboratory. Whereas compare that to the slide on the left, where someone is working in a BSL-3 laboratory, working inside a biosafety cabinet, using a PAPR, wearing gloves, gown, and which the picture doesn't show it, but I know the person was wearing shoe covers as well. So in this slide on the left, we're taking full precautions at biosafety level 3, something that would not have been done at the State Hygienic Lab in the 1950s. Moving on to the next slide, this is something that I put together called the evolution of biosafety. And it's just an interesting look back at biosafety in the past 50 years. There seems to have been 3 sentinel events. First, back in the early 1970s, it was recognized that laboratorians were at high risk for hepatitis B virus infections. As a result, there was a clampdown on eating and drinking and smoking in the laboratory. And I know you can't imagine anyone ever doing that, but I assure you that I saw it myself back in the 1970s. There were no federal requirements. However, there were requirements from the College of American Pathology standards. And this eventually became the norm, that no one was allowed to eat or drink, apply cosmetics, or smoke in the laboratory. Then in 1987, OSHA issued a directive addressing bloodborne pathogen exposure in the laboratory. And they made offering the hepatitis B virus vaccine a requirement and placed the term universal precautions into our vocabulary. This later became standard precautions, and later the employer was required to offer HepaVax at no charge to the employee. Starting in 1987, they didn't have to offer it at no charge. And then in 2005 was another sentinel event with the implementation of the select agent rule. That placed strict requirements on the handling of the select agents, organisms like Bacillus anthracis, Brucella, and others that are at high risk of being used in a terrorism event. Moving on to 2011, APHL and CDC issued biosafety competencies for laboratorians. And in 2012, there was another MMWR that was the Guidelines for Safe Work Practices in Medical Diagnostic Laboratories introduced. So our objectives today are to determine the reasons to perform a risk assessment, to discuss the biosafety risk evaluation process, provide you some examples of risk assessments in the microbiology lab, and look at the role of the risk assessment in the biosafety program in total. I look at biosafety in the laboratory as an infection control process. And this slide shows you from an infection control perspective what's known as the chain of infection, how infections are spread from the agent to a susceptible host, finding an entry site into the body, a means of spreading, then exiting to the body, to a reservoir, or onto another individual. Anywhere along that point, you can break the chain of infection. For example, if you vaccinate with hepatitis B, then hepatitis B virus being the agent, you vaccinate the susceptible host, you have broken the chain of infection, then because the person cannot acquire a hepatitis B virus infection because they have been vaccinated and have antibody to prevent an infection. So we look at means of preventing infection along this chain of infection. Looking at this slide, this gives you the typical portals of entry of biological agents. What are we concerned about from a laboratory perspective of acquiring an agent? First of all, our mucous membranes, the eyes, the nose, the mouth. We want to protect our mucous membranes from splash or splatter with a specimen or with an agent. We want to make sure that that's not the portal of entry. So using things like splash guards are very effective. Working inside the biosafety cabinet is another effective mitigation strategy. Another cause for concern is the protection from aerosols so that we don't breathe in a pathogen. For example, if we're processing specimens for TB, we want to be working in a biosafety cabinet, plus we want to be wearing a respirator to protect us from exposure to those aerosols. The gastrointestinal tract is another means of entry into a body for a biological agent. In the laboratory, we want to protect against splash, splatter, and ingestion. Typically in the lab, for example, if we're working in the lab, you don't touch something and then put your hands on your mouth so that you might ingest what got on your hands. You're wearing gloves, for example, so you make sure you don't touch your mouth with your gloves. Another means of entry is the skin. So you protect the skin from splash, splatter, contact, and puncture wounds. So we've done a lot in the laboratory to go to needleless systems so that we don't risk a puncture wound. So this shows you those portals of entry that I was referring to in the chain of infection slide prior to this. Going on to the next slide, I'm asking the question, what is risk? And I'll give you the basic definition. Risk is the likelihood of an undesirable event happening that involves a specific hazard or threat and has consequences. So you look at the following steps when you're looking for risk. So you're looking at what work is occurring in the laboratory to define the situation. So if you're working at a setup bench, you're working with specimens, and you're defining the situation of what you're doing with those specimens. You define the risk within the situation. What can go wrong? Well, you could drop the specimen. You could drop the blood tube, for example. That is the risk that can occur. What can go wrong? And you characterize the risk. How likely is it to happen? What are the consequences if the person does get an infection? So going through a risk assessment process is asking yourself a series of questions. What is occurring with the work? What can go wrong? How likely is it to happen? What are the consequences if the person gets an infection? Is there treatment? Is there not treatment available? So that is the basic questions you ask in the risk assessment. In this slide shows you the biorisk management process, what we call the AMP model. It starts with the assessment, it looks at selection of mitigation, and then performance, making sure the mitigation is used. Let's take the example of looking at an assessment of specimen processing. Everyone would accept the fact that you need to wear gloves when you're handling the specimens because they could be contaminated on the outside of the specimen container. You don't want that contamination to get on your skin. So your mitigation step is wearing gloves. Then performance of that requires documenting that gloves are to be worn, training people that gloves need to be worn, and monitoring to make certain that people continue to wear the gloves. So it's a three-part stool as demonstrated on the right: assessment, mitigation, and performance. Now, assessment can be defined as the process of identifying the hazards and evaluating the risks associated with biological agents and toxins. You need to take into account the adequacy of any existing controls, mitigation factors, and decide whether or not the remaining risks are acceptable. Now, recognize that risks are never going to be zero when working in the laboratory. The work itself entails potential risk of exposure to pathogens. Even though we're taking many precautions that weren't in that 1950s picture that I showed you, there's still risk that exists. We can't bring it down to zero, but we can bring it to an acceptable level so that we can do the work that is required, that we are there to do for the benefit of the patient. So bringing this all together, our risk assessment then is the risk is the probability that the health effect will occur after an individual has been exposed to a specified amount of hazard, that amount depending on the pathogen and the person's own immune status. The risk assessment is that process of gathering all the available information, and then that's followed by determining the mitigation strategies that are necessary to provide the protection. And again, asking questions like, what can go wrong? How likely is it? What are the consequences? And I think the how likely is it is a very important question, because we can't always guard against every single risk that could occur. We have to guard against what's reasonable to expect to occur. So defining mitigation, mitigations are taking actions and control measures that are put into place to reduce or eliminate the risk associated with working with biological agents and toxins. So the risk of working with TB is different than the risk of working with Staph aureus. So you're looking at the specific control measures for the particular pathogens in the particular work that is occurring in the laboratory. And you're looking at all of those control measures. And we're going to talk about the control measures from instrumentation to personal protective equipment like gloves. So if you're looking at your overall risk mitigation strategy, at that lower tier are the lab practices. You want everyone to be effective hand washers, good hand washing. You want there to be appropriate signage in your laboratory, that there's signs posted, no food or drink in the lab, etc. You need to have good workflow, and that's what that floor plan on the right describes. You typically go from clean to dirty areas in your workflow. Above that are PPE, like gowns and gloves and respirators. And above that are biosafety cabinets, centrifuge containers with the seal-capped tubes, and then your biosafety plan, which brings that all together. And you really need to have a written biosafety plan. And your risk assessment helps you to write that plan. Now this slide gives you the hierarchical of controls. The hierarchy of controls, rather. So at the top is physically remove the hazard. So just don't do the work. And we know that's not an option we have. Patients need the work that we do. It's vital to help the clinician make effective decisions, use antibiotics wisely, and to prevent others from getting an infection. Another way would be substitution. If you were in a research lab, you would typically use a less pathogenic strain of the organism. Another way are engineering controls. Just isolate the people from the hazard. And that's what the biosafety cabinet helps you to do. It helps you to isolate the employee from the hazard of working with a biological agent. Then there are administrative controls like your biosafety plan, your signage, your other things in place that you have in place. Then the bottom tier is the PPE, the personal protective equipment like the gloves, the gowns, the respirators. But as you can see from the left-hand side here, the least effective is the PPE. As you go up, for clinical labs, engineering controls are the best that we can do to isolate people from the hazard to prevent transmission. And when you're thinking of the biosafety levels for a laboratory like BSL 1 through 4, that's essentially what's occurring with engineering controls. So when you're thinking of your mitigation strategies, one of the first things you want to think about is there a mitigation through an engineering control, or does it need to be an administrative control, or lastly, would a PPE be the most effective control? So the implementation of the entire biorisk management system includes evaluating and ensuring that the system is working the way it was designed to work, and then you look at continually improving the system. So this is part of your quality management system process. And you should think of biosafety as an important component of quality management systems. So I'm asking here the question, why do a risk assessment? So you want to determine the relative level of risk that each activity that you're performing in the laboratory poses to the staff performing that activity. And then this guides the risk mitigation decision process. Now, I wanted to drive home the idea, though, that this is a balancing act. You're trying to balance the risk against performing the work. So you have your practices that you're going to implement to mitigate that risk on the one side of the scale. And on the other side of the scale, you're looking at the performance of work in an accurate and efficient manner. You know that how important the work that we do is. We also have to balance that with protecting ourselves from acquiring an infection. Now, as we do risk assessments, with this goal being the balancing, we also have to remember changes occur, and we should review our risk assessments at least annually. And we'll talk about reviewing them when other changes occur in our lab as well. But at least annually is a good thing to remember. Now, when you're performing a risk assessment, I like to put together what the work plan is. And the first thing that comes up on this slide is engage everyone, because people doing the work are most familiar with the processes. But someone has to put the process together in a risk assessment. So you create a risk assessment matrix for the agent, the protocol, and staff susceptibility to disease. So I'll show you some example of matrices that you can use to look at your risk assessment in the process. Then you identify the lab procedure hazards through a protocol-driven risk assessment. So I like to look at each step in a protocol and determine what is the risk of an exposure at this step. Then ask the question, what mitigation can be put in place to eliminate that risk or at least lower that risk? Then, of course, determine the appropriate biosafety level and risk mitigation steps. So biosafety level, for example, if you're processing TB, that should be performed in a BSL-3. You should consider what biosafety level needs to go in BSL-3 work and what needs to go in BSL-2. If you don't have a BSL-3, then you may determine that you may need to send out specimens to another lab that will do that work in a BSL-3. As part of your biosafety plan, it's really important to evaluate staff competency in utilization of safety equipment. We all know that after the Ebola crisis, one of the things that we have identified that came out of it is that people are not well trained in putting on PPE and taking off PPE, the donning and doffing processes. This is one area that's a good example that you can have a competency written on. Another competency may be utilization of a biosafety cabinet. The CDC recently put out through their train system a really good training video on using a biosafety cabinet. Reviewing that video could be part of a staff member's annual competency so that they are proficient at using a biosafety cabinet. And lastly, review your assessment with staff and management. Everyone should be engaged in the process, and reviewing the assessment is really an important part of that engagement. In my laboratories, I've signed off on the risk assessment after they have been performed so that I could be well versed in what staff are performing as the laboratory director. Your next question is, who's going to perform this risk assessment? Well, any number of people could be doing this, but you want it to be somebody who's knowledgeable, has had practical experience, and has good problem-solving skills. It can be a team approach, and possibly a team approach is the best, because you have members of staff, maybe you have a biosafety officer or an experienced individual who's responsible for biosafety, and they get together and go through the process of doing the risk assessment. The assessor needs to have knowledge of the facilities, safety principles, modes of transmission, the hazards, and the regulations that we're all under, whether they be local, state, or federal. So consequently, with all that someone needs to have knowledge of, a team approach is the most efficient. When to perform that risk assessment? Well, it's best to perform it before work begins. You want to be able to have anticipated the problems before people actually experience problems. So doing it before work begins is best, but that's not always possible. Whenever there's a move or renovation, it's good to do the risk assessment. If you have significant changes in personnel, turnover of staff, then redo your risk assessment. If there's an emerging infectious agent that your lab is now going to be receiving specimens for, then doing a risk assessment is the appropriate first step in addressing that emerging agent. And Ebola is a good example. When laboratories heard that there was the risk of Ebola, patients suspected of having Ebola being seen in hospitals in the United States, the best approach from hospitals, laboratorians, would be to do a risk assessment. If you get new equipment, do a risk assessment. Even before you purchase that equipment, do the risk assessment to see what risk there may be of acquiring an infection from that piece of equipment. And you repeat the process when there are changes made to reagents, practices, employees, or your facilities. So there's a lot of different times to consider performing the risk assessment. Now, another time to consider is on this slide, changes in manufacturers or suppliers. If there's been a recent accident, a lab-acquired infection, or maybe an exposure, or theft or security violation, then consider doing your risk assessment. A national or regional change in disease status, a new disease is endemic in your area, etc., then performing the risk assessment is appropriate. So I've broken this risk assessment process into 5 parts. I think it helps us to look at the components of what we have to accomplish. So the first would be define that situation. So look at the hazards that you're dealing with, defining the risk, and that has a lot to do with knowing what the organisms are, looking at the dose response, is there treatment for them, etc., and characterize the risk, looking at the likelihood versus the consequences. What's the organism you're dealing with? Is the host susceptible or not? Looking at those two, and we'll go in more depth on that. And then after you've determined what your mitigation steps are, looking at your remaining risk and determining if it's acceptable. Then you go back and periodically review it. So this is a 5-step process. So in this slide, if you look at along a continuance of time, you look how likely is the event to happen. Given that occurrence, what are the consequences? So these are the questions that you need to be asking yourself. Likelihood then is the likelihood of acquiring an infection after an exposure has occurred. And it's based on both the biological agents that are involved and the work practices, the work performed in that laboratory. The consequences are, will the person who's exposed acquire an infection, or will they need to take post-exposure antibiotics, or maybe there's a post-exposure vaccination that might be involved, to any at-risk individuals who are exposed. So we have likelihood and consequences that we have to consider in the risk assessment process. Give you an example. Specimen receiving, and we started talking about this before. What can go wrong during a specimen receiving process? I gave you the example of the outside of the container might be contaminated with a pathogen. Just looking at that container, you may not be able to see that it's visibly contaminated. So the question is, how likely is it? What factors do you have to consider in assessing this likelihood? Well, you know that the specimens are collected at the patient's bedside and they're sent to you. They could be spray, splash, splatter of blood on the outside of a blood culture bottle that you're not going to be able to see. What are the consequences? Well, there could be a bloodborne pathogen involved, could be another agent involved. Those are things that you have to consider, and that's why we have universal or standard precautions in place, because we want to consider any blood or body fluids potentially infectious. And what mitigation measures should you put into place to make the risk of the specimen receiving acceptable? So we talked about wearing gloves before. Decontaminating the outside of the specimen containers is also a wise choice, particularly if it's blood culture bottles and you're going to put it into a blood culture instrument. Decontaminate the outside, because somebody else is going to have to handle those blood culture bottles again, either when it's positive for growth or later on when you have to discard the negatives. Excuse me. Let's go on to the next slide. So I like to start with the potential pathogens involved. I've shown this picture, E. coli and Staph aureus. It's very common for a laboratory to encounter. But down at the bottom left-hand corner is a picture of Francisella tularensis, several-day-old culture, growing on chocolate agar. And on the right-hand side is H5N1 avian influenza. Labs throughout the country encounter both of these organisms. I know in Iowa this past week I was told of the case of Francisella tularensis from a blood culture. And there were exposures in the laboratory because the cultures were handled on the open bench. They did not recognize at first the potential for Francisella tularensis. This happens in laboratories from time to time. And if Francisella tularensis is common, endemic in your region of the country, that's one of the organisms that you have to consider in your risk assessment process. As is avian influenza. We've been seeing this in different parts of the country in past years, and so it's something you have to consider. It has potential. So the first part of this process is to estimate the risk based on the pathogen. What's the infectious dose? Some organisms have a very low infectious dose. I'm sure you'll recall that organisms like Microbacterium tuberculosis, only one organism can cause you to acquire the illness. Shigella, less than 10 organisms. So you want to think of that and think of the contagiousness of the organisms involved. How stable is that organism in the environment? Does it readily die? Or all organisms are susceptible to temperature, light, pH, desiccation, humidity. You have to think of their life cycle, their incubation period, their infectious period, and how are they transmitted. So these are all to be considered when you're looking at the pathogens that you're encountering. So when you're encountering a new emerging pathogen, you sometimes don't know all the answers. So sometimes you have to overcompensate because of the lack of knowledge that you have on it. But for the most part, you're dealing with organisms that you know or are familiar with. So when looking at pathogens, I like to fill out a matrix like this. I look at risk factors and the degree of laboratory risk. And I look at the agent, considering pathogenicity, virulence, infective dose, and transmission. And then rate them from low, moderate to high, and high. So for example, Salmonella typhimurium is an organism that has moderate pathogenicity, causes a mild to moderate disease. Mycobacterium tuberculosis is moderate to high. It causes serious disease, and But for the most part, what we encounter in the United States are susceptible mycobacterium tuberculosis. If we encountered multi-drug resistant or XDR TB, then it would be a different situation. We may move that to high as laboratory risk. And severe disease with herpesvirus B being an example of that. Infectious dose is also listed here. Vibrio cholera has a very high infectious dose. Influenza, anywhere from 10 to a 6 to 100 organisms. Francisella, though, less than 100 organisms can cause disease. And how do you acquire it? Is it through contact, surfaces? I've listed here animal bedding, but that's not for clinical labs. But is it direct contact or is it inhalation? So this is the type of matrix that you could create if you were looking just at pathogens. Another way to do this, though, to approach this, is by looking at a protocol-driven risk assessment. So you're looking at the lab activities that drive the level of containment and the mitigation that you need to implement. Or on the high end, a good example is HIV amplification, because if you're going to amplify the number of HIV particles, that's going to increase your risk of exposure, leads to increase in the level of containment. You would do this in a biosafety level 3 laboratory. But most clinical labs don't do this. If you ask the question now, how do laboratories get infected? We have this review from the Clinical Microbiology Reviews from Sewell et al. And from 1995. They looked in and found that needle sticks and sharp injuries were the top reason for laboratorians to get infected. This was followed by inhalation of aerosols, and then ingestion. Ocular and mucosal splash or contact was in there as well, and then some rarer routes for clinical laboratorians followed. So in this slide, this is from that same article in Table 5. This looks at activities that generate aerosols. You have your inoculating loop manipulation. So even streaking for isolation can cause aerosolization. If you're pipetting, and depending on whether you're just transferring or you're pipetting to break something up to mix a microbial suspension, that can cause generation of aerosols. Then, of course, needles for syringe manipulation, and then others like centrifugation, vortexing, decanning, things like that, all cause the risk of aerosols. All are steps that generate aerosols. So if you're going to create a matrix to look at a protocol-driven hazard assessment, then you're going to look at the agent concentration, the suspension of volume, generation of droplets, etc., under protocol hazards. And you can rank that too as low, moderate, or high. And this could be depending on the organisms that you typically work with in your laboratory. So you look at things at low risk as being less than 1,000 organisms, less than 1 ml in volume, streaking smooth agar, standard repetitive procedures, and those are all low-risk activities. On the high-risk side, though, if you're dealing with agent in really high concentration, greater than 10 to the 9th, greater than a liter of fluid, if you're flaming and inoculating loop, for example, frequent change in complex procedures that you might be following, then those are at higher risk. So then you can also have to look at those who would be susceptible to the disease. So look at the potential for exposure, the individual susceptibility, the availability of vaccine or other prophylaxis like antibiotic therapy, and available of effective treatments. So on the low to moderate, moderate to high, and high scale, you have potential for exposure. Visitors to the laboratory have very low risk of exposure. But if they were in the lab when you were working with something like Brucella, then there would be a higher risk for them to have exposure. So then you can go across, but the most high being the lab worker who handles the agent in the laboratory, having the highest risk of exposure. The individual susceptibility goes the same way. If somebody's been effectively immunized, they're at a low risk. But if they're immunocompetent, they're at a moderate to high risk. But if somebody is immunocompromised, and this could be for a number of reasons, maybe they're taking some treatment for a disease, for example, that could pose them to be immunocompromised, then they're at high risk. Let's look at the example of Neisseria meningitis. We know that this requires a biosafety level 2, and BSL-3 practices both working within a biosafety cabinet, protecting from aerosol and droplet precautions. And why do we know this? It's because in the literature there are multiple reports of lab-acquired infections with Neisseria meningitis from laboratory technologists, and 12 out of 32 of these lab-acquired infections were fatal. And it could be simple as doing a catalase test on an open bench that was the source of exposure, maybe preparing a gram stain of a colony. What we're worried about, and that's why I have the picture of the plates here, is working with the amplified Neisseria meningitis. There's not a risk from working with the spinal fluid before it's amplified or receiving a blood culture bottle. But if you're growing the organism in a blood culture bottle, you should always do your subculture and gram stain preparation inside the biosafety cabinet because you've amplified the organism. So just to give you some idea for what epidemiologists calculate, there are over 3,000 isolates of Neisseria meningitis per year. The estimated attack risk is about 13 per 100,000 lab techs versus only 0.3 per 100,000 individual adults aged 30 to 59. So that's the general population. So when you compare lab techs to general adult population, lab techs have a 13-time greater risk of acquiring the infection than the general population does for that age group. This slide shows you from Sejvar et al. The list of cases, and I've put in red boxes the fatalities. These were experienced laboratorians. You can see from the ages of the patient, for example, this patient being 46 years old, this one being 40 years old, 45, 52, 65 years old. These were experienced laboratorians who acquired these infections. Several survived, but there were a number of fatalities. So this is a large risk for us in the laboratory. So if you were to fill out this matrix then for Neisseria meningitis, you would say it's a high risk because there's severe disease. It's a very lethal disease because there's been deaths associated with it. The infective dose is low, and the inhalation is through aerosols. So you want to work inside a biosafety cabinet to protect yourself from getting this exposure to this organism. To go on with your risk assessment, if you're working with a plate, you're going to have a really high concentration of organisms or a blood culture bottle. And if you're generating droplets and droplet nuclei, you can do so by just making a suspension for a gram stain on a bench top. So, but there is a vaccine for Neisseria meningitis, and that is very important to consider here on this slide. Now there is new vaccine, and you can, all the serotypes are covered. But not everyone has received the latest of the vaccines, so it's well worthwhile to talk to your occupational health department and see if you can have your staff be offered this newer vaccine where all the serotypes are covered. Now, let's look at a risk assessment that's protocol driven. And the example I have here is a subculture of a positive blood culture. I've listed what the potential hazards are: aerosols, splash, and splatter. I've listed what the controls could be: working inside a biosafety cabinet and wearing PPE. So, and I've listed out what that PPE would be: fluid-resistant back-closing gown, double gloves, N95 respirator, goggles, full face shield. So you have everything listed here that the individual should be using. So then you can also put in comments: bring all the necessary material onto the biosafety cabinet before starting the work. Do not enter and re-enter the biosafety cabinet once specimen processing begins. So this tells you what your risks are from performing that activity, what the potential hazards are, what mitigation there could be, and what training you need to do, because you need to be training your staff on how to effectively use a biosafety cabinet so they don't expose themselves from misusing that biosafety cabinet. Here's a second example. This is Mycobacterium tuberculosis performing susceptibility testing. So you've grown up the organism, and now you're going to inoculate the broths for susceptibility testing. And here again, your potential hazards are aerosol generation. You could spill it, could leak, etc. People are exposed while manipulating the solid culture in the tube, so there's moderate risk. And there is risk from exposure to the liquid culture. That's a higher risk. So you have your PPE listed again, working in a BSL-3 laboratory, or some people use BSL-3 precautions while working in a BSL-2 if they don't have that available to them. That can be considered as well. All culture manipulations performed inside a biosafety cabinet on disinfectant-soaked pads. So if you get any splash or splatter, it drops on those pads and the disinfectant will kill it. And then you dispose of the inoculating loops and transfer pipettes, etc., in a rigid container containing disinfectant, and you keep that container inside your biosafety cabinet so your hands aren't going in and out with your inoculating loops. So this sort of summarizes what I was talking about before with likelihood and consequences. So if you look at increasing likelihood and increasing consequences, when your likelihood is low and your consequences is low, then you have a very safe situation. But if it's moderate or high, then you have to consider your mitigation steps. So for a glucose test, you see there's a broken tube of blood in the centrifuge. Well, where would you put the likelihood in the consequences here? It's just a blood glucose test. There's no infectious process going on here that you know of. So, but there could be a bloodborne pathogen issue. So, of course, you have to be concerned of that. But hopefully everybody in your laboratory has received hepatitis B virus, but there's hepatitis C and HIV to be concerned as well. So there are consequences associated here. If you have, on this example, a positive TB midget tube breaks on removal, well, that's a very high likelihood of exposure to aerosols, and also very moderate to high consequences, because that could be a multi-drug resistant TB. You don't know at this point. So here's another situation. An owner wants a pet back after it's being tested for rabies. Well, there's no treatment for rabies. And once something's been in the rabies laboratory, it could be cross-contaminated from other positive rabies samples. So high likelihood and high consequences. So you naturally would not allow that pet to leave that laboratory. Now, I mentioned host factors to consider before. I'd like to cover this a little bit more depth. Pregnancy is considered a host factor that puts you at greater risk of acquiring infection. There are medications that we commonly take that could put us at a higher risk of acquiring an infection. Breaks in the skin, using an inhaler in the laboratory, for example, would put you at higher risk of infection. Someone who's extremely tired, as typified in this bottom right hand picture, could put you at high risk of acquiring an infection. It's important to consider what vaccines you're going to offer in your laboratory based on what testing you're doing, what protocols you perform. Hepatitis B, of course, is required through OSHA. Very good idea to have tetanus and diphtheria offered. Influenza on an annual basis should be offered and encouraged. Pneumococcal vaccine might be considered, hepatitis A, measles, mumps, rubella, varicella, and for your microbiology staff, meningococcal vaccine is recommended. If you do rabies testing or anthrax work, you would consider those as well. You want to write this into your occupational health SOP. You want to have a process for reporting events and illnesses, events meaning incidents, exposure incidents. How are you going to respond to potential exposure events? Staff need to know exactly what is expected of them if they get exposed, so that they will take the steps as quickly as possible. How do you respond to respiratory illness in laboratory workers? Do you worry that it could have been laboratory acquired? What's your response for illness with your post-exposure prophylaxis? Do you do fever watches? What occurs if somebody goes on antibiotic therapy, etc.? What if somebody needs laboratory testing? And how do you decide when a person's ready to return to work? All these should be in your SOP. So at a minimum, your practices should include offering hepatitis B immunization and other immunizations as available and based on the expected work areas such as the Neisseria meningitidis vaccine for those who work in microbiology. And then you want an ongoing evaluation if in the respirator program somebody's enrolled in wearing a respirator, they need to have an evaluation at least annually. Now, this final slide is titled, Are You Making These Risk Assessment Blunders? And this is from David Kant. I found it at this link below. And these are the blunders that he's referring to. Not doing a risk assessment, not properly identifying your hazards, not creating an inadequate risk assessment, assuming safety practices because you have a document without doing the training of your staff and putting things and watching for compliance with these activities. Not involving your employees. All the staff need to know what's expected of them and why it's expected of them. And another blunder is assessing risk generically, not looking at your specific workplace. You have to craft your risk assessment process for your particular work environment. That's my last slide. I'll turn it back over to Christina.
Thank you, Dr. Pentella, for that informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the green Q&A button at the lower left of the presentation window. Type your question into the box that appears on your screen and click the send button. We'll answer as many questions as we have time for. Let's get started. And our first question asks, my lab does not allow the use of cell phones in the lab. Are cell phones a biosafety risk?
Are definitely a biosafety risk. When you bring a cell phone into the laboratory, you risk contaminating that cell phone with what you're working with in the laboratory. And you also need to consider where you're taking that cell phone afterwards. I know people who use cell phones to look up recipes while they're cooking dinner. So if you have your laboratory in the lab, your cell phone in the lab all day, and then you go home and use your cell phone while cooking dinner, you risk contaminating your food with what you've worked with. If you've worked on the enteric bench that day, it's not a good idea. There's an ongoing outbreak with salmonella because of people taking things from the laboratory, out of the laboratory, into where they're eating. So you definitely need to be concerned about cell phones, and restricting cell phone use in the laboratory is a very wise thing for a laboratory to do. Do we have any more questions? I'll hold on. I'm told we have just a little technical problem. So hold on for our resolution of this technical.
Thank you so much. Okay, our next question of the day. This question asks, our lab is getting a moldy top. Are these biosafety risks that we should consider?
And it's becoming much more common in laboratories today. It's a great instrument. My lab has a moldy top. I think it's excellent. But you also have to consider that the processes in use with a moldy top. For example, if you're going to spotting, direct spotting, you're not going to be killing the organism. So consequently, you have to be concerned, what if that's a highly pathogenic organism that you're using? Maybe you want to use the tube method to kill it, kill the organism. Another thing you need to consider is the other processes don't disappear, like the need for gram stain. Take the Francisella tularensis example for the organism as an example. If you were directly to go from that plate to the moldy top, A, that organism isn't in the database for moldy top at this time. And B, you might get a misidentification. You will have worked with it on an open bench. So the processes that you need to be aware of, the Sentinel lab protocols that are put forth by ASM, still are in place. And you still need to take all those same precautions of using a biosafety cabinet to do the gram stain on a suspected Francisella tularensis. So your processes still have to account for those risks. So when you get a moldy top, you should consider your processes and do a risk assessment for that instrument before you put it to work in your laboratory. Are there any further questions?
Yes, thank you. Actually, there is. This will be the last question of the day since we're running tight on time. Do some labs include biosafety competencies in the annual competency assessment program?
And it's a really good idea. Just like we have competencies for using instruments or performing tests, we should have competencies for biosafety as well. Competency for using a biosafety cabinet. Competencies for donning and doffing PPE. Competencies for spill cleanup. Those are just 3 examples of things that you could do in your laboratory to incorporate competencies into your biosafety into your competency program. Back to you, Christina.
Excellent. I would like to once again thank Dr. Pentella for his presentation. I would also like to thank LabRoots for making this educational webcast possible. Before we go, I want to let everyone know that today's webcast will be available for on-demand viewing through February of 2018. You will be emailed letting you know when the webcast will be available for replay. Please share that announcement with your colleagues who may have missed today's live event. That's all for now. Thank you for joining us. We hope to see you here again soon at LabRoots. Goodbye.